Hey everyone, welcome back to Beyond Quality. Before we get to today's episode, 30 seconds on an upcoming conference hosted by Rise, our season 1 collaborator. Rise West is being held September 2nd through the 4th in San Diego. 500 plus Medicare Advantage senior leaders and provides direct access to OIG, attorneys, industry experts, and health plan execs. I don't think we've ever had attorneys be a key draw before, but this is the world we live in. It will have interactive roundtables, workshops, Q&A, and 2 dedicated tracks so you can focus on the topics that matter most to you. Use code BeyondVIP at risehealth.org/beyond to save 20%. Quality improvement in healthcare. It's typically described as a framework for systematically improving care. In reality, it's an endless struggle to align policy, data, and processes with human behavior. Join the RWC team and guests from across the industry as we tackle the toughest challenges facing quality today. From culture to capital, from strategy to technology, join us as we go beyond quality. Now on to our episode today, margin compression, MLR, and GLP1s. Oh my. Across the health plan industry and every line of business, the financial backdrop right now is brutal. Benefit degradations, organization restructuring, and market exits are topics being discussed inside virtually every health plan in 2026. Let's get into this. I'd like to introduce my co-host today and our guest. My co-host is a consultant that works with me at RWC. She has deep experience in quality improvement with an exceptionally deep expertise in all things related to value-based care. Please welcome Paige Caprara. Hi, Paige.
Hi.
And then our guest today is the Chief Financial Officer at Community Health Choice, a health plan right here in Houston, where I live, that serves underserved populations and does great work here. Please welcome Anna Mateja. Welcome, Anna.
Well, thank you. Great to be here with you.
So thanks for joining us. Yeah, Paige and Anna both. Can you guys give the listeners just a little more background on yourselves so they can understand kind of who's on today? So Paige, can you start?
Sure. Yeah. So Paige Caprara, I reside in Columbus, Ohio at the moment. Been in a couple of different areas around the country, Houston being one of them. I didn't live there, but I was there every other week for about a year and a half for business development position with an IPA, CIN, ACO out of our national one. So I've been about 15 years in the Medicare Advantage space. A lot of provider relations, kind of in provider engagement background, but a lot with traditional Medicare through the ACOs, as well as the clinically integrated networks and the Independent Physician Association. So STARS is close to home in all of those realms, and also was very fortunate to have a team of analytical strategists at Centene for a little bit that, we kind of consulted with each one of the regional plans. So we love the regional plan piece of life. Those local close to home plans make a huge difference in the communities. So yeah, happy. Oh, and I've been working with community health for about a year and a half. So yeah, happy to have Anna on with us too.
Yeah, so excited. Yeah. Thank you, Paige. How about you, Anna?
Yes, Anna Mateja. I'm the CFO here at Community Health Choice, and I started my career back in 1988. So I've been in healthcare almost 38 years now. Had a little experience in the consulting area, the hospital side. I've sat on that side of the bench, and then was part of a startup health plan, and then here at Community. And I guess I'll share on a personal level. As I'm moving towards the back end of my my career, health and fitness is something really important to me. And I started running, and I did a marathon, recently.
Oh, cool.
In my 50s. And so it's just been really interesting thinking about health and fitness being in the healthcare industry.
Very cool.
Yeah, wow. I started running when I was in my 50s too, and ran a half marathon I guess in 2023, and haven't run anything since. It was a big thing to check off my list, but my knee felt it for sure, and I don't know. I gotta get back into it though. In Houston, it's not that easy, right, Anna? There's not.
It's hot.
It's hot.
It's hot. Yeah.
It's hot. Well, let's jump in. So Anna, we'll start with something kind of light and fun here. Not really. Can you walk us through what keeps a health plan CFO up at night in 2026? And how does that differ from 3 to 4 years ago?
Yeah, that's such a great question. as I'm thinking about the question, the role of a CFO is really to ensure the solvency of the organization and make sure that we're here for the long haul. And so we're constantly looking at what our forecast is for the future, setting that goal for what the future is, and then we're measuring performance to see how are we tracking against what those goals are that we set. And what makes that easy is when you have predictable situations. And we've just had so much change in our industry that creates a lot of complexity. Medical cost is definitely an issue. It's always been an issue, monitoring medical cost and setting rates. Those are two important things. But I think the membership transition that we are experiencing more recently is a really compounding impact. There's a lot of legislative impacts that are driving that on the marketplace side, the subsidy issue, whether the subsidies would be extended, and of course they were not. And so when that happened, the concern about membership contraction, and we did see some level of contraction, different, maybe a little bit different than what was projected, but that contraction has resulted in a change in the average mix and acuity of members, and it's impacted the revenue streams that we get for risk adjustment in ways that were unexpected. And you saw last year about this time where many health plans had to retract their earnings reports because of that, of that single factor. And so today there's just so much we are dealing with, not just medical costs. You mentioned GLP1s, different cost drivers, setting prices for healthcare to ensure that healthcare is affordable and accessible, but then also these other factors around how our members are changing because healthcare is just becoming so expensive. Some people are just unable to choose to continue to afford insurance, and how that's affecting other downstream impacts that create lots of complexity for our organizations. You back it up a few years ago, our issues were around coming out of COVID and how healthcare had sort of compressed to lower levels of utilization. And so just major shifts in what we're focusing on today.
Do you feel like what we're experiencing today is still related to the pandemic a bit, or are we beyond that?
Well, we've definitely transitioned, and there are things that are changing, but I think there are still compounding factors that are happening. The pandemic, even though it started in 2020, the unwinding of the pandemic really, we felt that in 24, and the contraction of membership was really significant in the rate setting process, because oftentimes the revenue that we get is based on usually historical information. And so one of the issues that we find is that it takes so much time for that information to inform the revenue side of the house. But today you're experiencing new trends on the cost side. And so that alignment between your revenue and expense is a challenging thing to mix when you have that timing delay on what's informing your revenue. But I do think care delivery is also still being assessed on the impacts from the pandemic, how it was delivered, and what we've learned about what is needed. You're seeing some of that transition now, certainly escalation in utilization levels, but we are still being impacted by some of the learnings from COVID and care delivery.
I was at Kroger the other day, and just a quick trip in there, and I've never they have the posts in front of the door to prevent cars from driving through there. There's 12 concrete posts, right? Every one of them on both sides, on both doors, had a sign for GLP1s. And like advertising, hey, you can get your GLP1 here at Kroger. And I know so many people on GLP1s and so many people experiencing amazing benefits that are affecting so many different parts of their life. Not, like weight is just the beginning, but when you lose weight, if you need to lose weight, it positively affects so many other places in your life. So, but it's so expensive, and it's so, it's in the marketing and advertising that Big Pharma and everyone else does for that. Just the cost is enormous, right? So I have to think, if I'm in some of those rooms at a health plan discussing finances, that's such a big topic by itself, I would imagine, right now with the GLP1s.
Yeah, it's the GLP1s are definitely what we're seeing is the usage of those drugs, not exclusively for weight loss, but for certain disease states. And so that is
Right. What they're
where
intended for originally, right?
what they're intended for,
Yeah.
and
Yeah.
where they're covered under your
Yeah.
plans.
Right.
And
Right.
so we're seeing certainly in diabetes and certain other disease states, some cardio conditions where the GLP-1s are indicated, and the impact on drug cost is really incredibly significant. The percent of total is, exceeding 50% of your spend in certain disease states, specifically for
Jeez.
GLP-1s, and that's increased to almost 70% in some more recent periods.
And not that we can say that GLPs are the reason that plans are exiting markets, but we see a lot of plans over the last few years exiting counties or exiting full states, and even regional, or some plans just closing down. When a finance team is looking at those numbers, like what kind of things are tipping those scales? Again, probably not just GLP expenses, but like
Yeah.
what's the tipping the scale between like we're just going to restructure things or change our benefits versus like we need to leave this market?
Interesting question. When I was in a different organization, I did an orientation program for people coming into the plan. And one of the questions I would ask them is, what do they think the single factor is that most influences an organization? Like, think of one thing that most influences an organization. And since I was the CFO, people always said money or, something financial. And I'm sure there's probably not one really right answer, but the answer that I was looking for is ownership. Company ownership. And you think about healthcare organizations, you have private organizations that might be owned by a small, an individual, possibly larger organizations that are either nonprofit companies or for-profit companies. And that is really significant when you're in finance classes as a student, you learn that there's one objective for profit organizations that are owned by stockholders, and that is to maximize shareholders' wealth. And, so that's basically, you want to make money so you can pay dividends, keep an elevated price for people that are investing in your company. The nonprofit organizations have a different structure. They're not owned by shareholders. They're not owned by anyone. They're community assets, and they have an obligation to serve the community. They're usually led by volunteer boards of people that are really looking at how you're spending your money to reinvest in your mission. And so they're very different kinds of organizations. And so your question is really interesting. I think my career has been on the nonprofit side. So, I have to acknowledge that. But I think as some of the organizations that have exited have a lot of pressure being publicly traded and needing to perform financially, make the margin, and be true to their shareholders. As a mission-based organization, we are trying to serve the community and be a long-term safety net organization providing access to coverage. And so I think that does impact some of the decision-making. But ultimately, as the financial leader, there are regulations that require us, all insurance companies, to have solvency levels. And we have to meet those solvency levels consistently year over year. And the solvency levels is like a savings account. It's how much money you have in your account. And that's important because Texas Department of Insurance doesn't want insurance companies to go bankrupt and then leave members without coverage. And so they've put in these regulations that impose that. And so for us, really, there's a threshold of whether you can sustain a product, ensure that it's financially viable and not impacting you to a point to deteriorate your ability to be financially solvent. Does that make sense?
Yeah, definitely.
It's such an important, I think, dichotomy between for-profit and non-profit or not-for-profit even. But we serve, Paige and I serve a lot of health plans that are both. Like some are for-profit and some are not. And I know many of the non-profit plans or not-for-profit plans, they feel this obligation like you feel, right, to serve the community and to not exit if at all possible. And we see so many of them. They're the last one standing in a county that is a very challenging county financially for a health plan. That's why, everyone else has exited it. But this community focused plan, who feels like they maybe have to cover the whole state or the whole area where they're in, they don't feel like they can unless they just have to. And I imagine that tension between sustainability and solvency and in serving the community for someone like you, it's probably, there's more tension there than with anyone else in the organization. I'm imagining. So yeah, that's got to be difficult managing that tension. I don't envy you on it. But kudos to you guys for, like, I know you fight so hard to serve. Paige and I also work in, we do most of our work in the quality improvement space, and right, and at least in Medicare Advantage, there's quality bonus payments that are important from a revenue perspective, and there's revenue impacts obviously to Medicaid as well that are very meaningful. But when there's so much, when margins are tight and there's not a lot of money to just say, hey, here's some money to go hire a vendor or go launch an initiative. When these quality bonus payments are so hard to get, cut points are getting tighter, there's not a lot of money to invest. How should quality leaders make the financial case to their CFO for continued investment?
I appreciate that question. I feel that quality and finance is a really important partnership within a health plan, and those two departments need to work really closely. Really, medical affairs in totality, but quality is a really important subset within the medical affairs area. What I would encourage quality leaders to do in working with the finance folks is to really make sure that you start with the things that you're doing today and show what are the measured results that you can demonstrate on the programs that you're administering today. And I feel like that establishes credibility with the finance leaders, because they see you're going to measure the results of the programs that you're doing. You have a mechanism and a structure to do that, and you're tracking your success. And by having that track record, it builds confidence from the finance team that we have a process, we have a partnership where if we make that investment, we'll be able to validate the benefit of that investment downstream. And so often that's really the challenge, is helping clinical leaders and other non-finance people in the organization understand what it takes to measure and evaluate financially whether something's working or not working. And that's just such an important part. So I would encourage people to start with, what are you doing, and sort of build that track record with your finance team. The return on investment is the place that we start when we're talking about new initiatives. And a lot of people will go to peer-reviewed information and pull down, statistics about this is going to save you so much money. I would encourage quality leaders to really break it down and think about short-term versus long-term returns. So much of healthcare programs that we put in place are not things that have an ROI in year. It takes time, right? There's a long runway. And so there's a lot of pressure financially right now, even on thinking, if you put yourself in the CEO hat, answering to the board, there's a lot of pressure to perform today with all of these headwinds that we're facing. And so we have to have a balance between initiatives that will help us in the short run versus initiatives that will help us in the long run. And so thinking about sort of your two buckets of opportunity. And then the other piece that I would say that people don't maybe vet out as well as we should when ideas are brought to finance is the cost. And we think we know the cost. It's easy. If it's a vendor, you identify the vendor cost. But that's not really where it stops. You have internal resources that are needed within your own department. Your dedication to one project is going to take away focus on other projects, but you're also probably going to need support from your IT partners, right? There's few projects that I see that don't require some level of IT support. And so understanding how you're creating demand on other aspects of the company, other components, and what that lift is, how much time investment is needed. That is really important because we have limited resources in those support areas of analytics and IT, and being able to articulate what your need is, what that cost is relative to the value that you're getting at, and figuring out how you're prioritizing your portfolio of opportunities is really important. And separating the short term versus the long term aspect of that. Because the other thing is you could have a project that has great opportunity 3 years from now, but you're going to get hit this year with all the cost. Well, it's going to flip your P&L this year adversely for the promise of 2 years down the road. And so, understanding the timing of the revenue and the expense is really important.
Right. It's such a helpful answer, and in lots of context around that. When you say the cost doesn't stop with look if it's a vendor solution, right? Like that's so helpful too. Like if I'm a quality leader launching a vendor, to understand that I need to pull the thread all the way through, right? Like not stop at the vendor cost. And it makes me think, I hear so many vendors say there's no IT lift required for our solution, right? And but typically when they say that, there is a huge lift maybe on the business owner to have lots of data to input into a system. So IT is probably, there probably is still an IT lift, obviously, but even if not, there's a huge lift on the business owner, I feel like. So to go get their own data.
It may not be that, let's say it's a file you're leveraging, the same file you send to a different vendor or with that same vendor. So it's not something that you need to do incrementally to start up or to implement. But once you get whatever the value is out of that project, oftentimes that result is something that you need to deploy some other place. You want to communicate that downstream to your providers, right? To change behavior maybe. And so that also takes data interface, thought around your how you're going to deploy that. Is that through a portal? Is that how is that going to occur? And then internal resources around how you educate the provider community around that. So it's a provider relations investment. Do they have capacity to do that? Is that the most important thing for them to be communicating on? Will they do that? And if they don't, do you get the value out of what's being promised? So it has to be thought through end to end as a project to be considered. And if the leaders that are thinking about these opportunities don't think about it from an end to end perspective, they're going to hit some barriers along the way, I feel.
And probably not get the buy-in they need from finance, right? If they haven't thought through that and can't articulate that whole end-to-end experience.
Or for a finance team that's not as experienced to ask those questions that you're asking.
Right.
If you don't know what to expect as a full system, if you don't know what to expect in a year and a half from this project, that project could essentially die, is what you're saying, because no one was ready for the additional time cost or bandwidth cost that would be expected. It's really good. So if I'm hearing you correctly, it's what do we need to do to set up for this initiative? What do we need, like maybe the first 6 months for initiative? What does the first year look like? And what does 2 years down the road look like? And something like that.
Yeah. And I think it's really important to think about what your success metrics are on the back end. What are you trying to change? And usually quality people think in those terms. What are those success metrics that I'm going to measure that's going to prove that I'm generating the outcome that I'm wanting, and showing how you're tracking that and how that number is changing over time.
And back to that, you said at the beginning, bring similar things that are doing well, so you can say we're adding all to this. But on the other side of that vulnerability piece of this is also where we have failed. We've measured it and we thought we had these expectations, but even showing an expectation that we had, we planned as well as we could possibly plan. These are the missteps that we had, and this is why this situation failed, and this is why we need a different initiative. So not just I'm hearing not just successes, but just show that you can measure whether it's good or bad. I think that makes a big difference.
I think willingness to fail is important for healthcare. It's it's not always going to be perfect, and there you're not always going to do things that have the impact that you want. So you want to fail fast.
Hmm.
But how do you know if you're failing fast if you don't measure it? So that's where,
Right.
I just completely what you just said, Paige, is so important. It's being able to measure and then just coming forward and acknowledging that and changing and iterating off of that learning.
The best advice I got very, very early on in my career from a quality leader, a clinical quality leader, was, she was exiting and I didn't know her well enough. I knew her well enough to know that she knew everything. And I just asked her, like, I just need, like, on your way out, like, one piece of advice. And she just said, fast failures. Just fail quickly and get right back up and maybe fail again, but maybe be successful. And that has really made a huge difference in the way I, communicate about different initiatives, but being
When I
willing
was
to fail.
when I was in grad school, it was at University of Arkansas, and we had a big partnership with Walmart because they're based there. So we're meeting with the Walmart executives and doing this big project, and they tell us their motto is ready, fire, aim, right? Like they want to move fast. And I've heard health plan leaders give great presentations on the importance of making fast decisions, right? Not struggling with the same decision for weeks or months and continuing to talk like in an executive steering committee, continuing to talk about the same things without making a decision. Now everyone can't. They're ready, fire, aim. You obviously they're big enough they can make a huge mistake and still be okay, right? Like everyone is not in that position. I get, but what you guys are saying, I so agree with. Fail fast, innovate. Try new things, and be willing to risk.
Yeah, definitely. Innovation comes from failure. You don't come up with anything new if everything is working just right. But I know we've taken a lot of your time. I just want to ask one last, if we're, so 2030, there are so many things that are, supposedly happening with CMS and HPMS and everything. And like 2030, all of these things have to be in a row. What do you think we're going to be talking about instead of like margin compression?
Well, you want to know what I'd like to be talking about instead of margin compression. I shared with you that I started running late in life, and I've just been thinking a lot about the healthcare industry and what we focus on. And, maybe this may be a little bit non-traditional financial feedback, but I would really love to see the industry get to a space where we could shift more to a healthcare focus. And we talk about healthcare. I think about my days on the hospital side, and our measures of success were hospital census, how many people were in the beds, right? That was an important statistic. And we built a lot of healthcare bricks and mortar. And I think there's an opportunity maybe for healthcare to shift more virtually, and that there's also an opportunity to have more focus on health as opposed to just sick care. And I would love to see us figure out a way with quality to what our quality metrics are. I look at the quality metrics that we use today, the HEDIS metrics, and they're so, process measured, and they're such things that people don't really care about. They don't really care about the idea of whether I got my well visit by itself is not a satisfying thing for me as a mom to think about. It's really, I want my child to be healthy and learning and thriving. And so how could quality metrics shift more to measures of things that people really care about as an older person, your true mobility? And I would love to see us figure out how healthcare providers are truly incented to measure those things and use that as the barometer of success, and integrate that into value-based contracting where there's more alignment. Part of the issue I see is that you've got so many separate entities. You've got hospital entities, health provider entities. And if we could have greater integration of the financial incentives of those organizations in delivering care that aligns with what outcomes people really care about, that's what I would love to see in 2030.
Yeah, I think that's amazing. When I first started in the ACO world, like the traditional Medicare world, it was the whole point was to keep people out of the hospital, right? To lower the cost and improve quality. But when you're attached to a health system, like you're saying, the heads in beds was what the margin was expected on the hospital side. So you're in complete contrast with each other. And I feel like in the last 15 years, things are getting better, but they're not completely aligned. Like you're saying, we are not truly in the healthcare space. We're in the sick space. Like let's figure out how we can help the sick people, but we're needing to move more towards healthy. And the last thing I'll say about that too is we talk a lot, or I especially talk a lot with our clients about making sure that they understand the spirit of the measure. I used to make fun of that statement, but now I use it all of the time. Like what is CMS really trying to do with these measures? And we have health outcome surveys, which is, very Medicare in depth, but CMS is trying, right? They're trying to get to where we can measure outcomes versus those process measures. But we had to like wedge people in or like step by step to get, but it's been a long enough time that we've been measuring breast cancer screening. Like, what are we doing with those screenings? What are we doing with the wellness exams? But yeah, I completely agree.
Is there a measure you think that approaches something that people care about more? I was talking with our quality director, and there's engagement with some of the accrediting organizations around testing new measures and coming up with new measures. And I was really excited about that. And I said, well, what's the new measure that they're talking about? And then I was a little bit disappointed when I heard what it was. It didn't, it didn't transcend to what I was hoping to hear. But I was wondering if you had thoughts on that.
I have a lot of thoughts on that, and I'm sure Rex does too. But my initial thoughts are we're getting to a good place when we talk about blood pressure controlled, right? It used to just be, did you take the blood pressure? And now is the blood pressure within control? So we're talking about how are we actually having a positive outcome? And same with the A1C measures. They've all changed. The names have changed, but in reality, we've been measuring, are you within a good range? And that used to just be, is it like have different ranges for different measures depending on which health plan you were working with. And but one of the measures that kicks me all the time for DSNP, for SNP plans, is did you do their HRA? And well, do you know how many plans do HRAs and have no clue what they're supposed to do with those HRAs? Like that is a wealth of knowledge on how to take care of those members. And so I feel like the next step needs to be like all of those outcomes. Let's take every process measure that we're doing and turn it into. And it seems like it's tracking that way. They're trying. CMS is very
if we could get the HRA to have a goal for what you want the patient to do.
Exactly.
And then are they successful in achieving the goal? That would be, a really great place to be.
We have the newest measure in Medicare Stars is a depression measure. Finally, we haven't really had one like this where, and I feel like that's a meaningful measure that's actually going to do some good, or at least it's got a good spirit behind it, like Paige said. But where, because we're actually assessing, like, if you are diagnosed with depression, did you actually receive follow-up care? Like, what was there a next step? Not just did you get diagnosed, not just did you do this, but actually is the health plan doing and the system doing something to help the member on that journey, right? So. But we have a long way to go. What you're asking for, it should not be as aspirational as it feels, right? Like it should not be like it should be where we already are. But it feels so aspirational what you're asking for to say measures that really mean something and to the patient as well. But we'll keep doing work and hopefully get there at some point. So Anna, thank you so much. We'll wrap there. Actually, one last question. Just like if people want to know more about you or want to follow you, are you active on social media, or can they like follow you on the community website or anything like that?
I do have a LinkedIn account. I'm not super active on social media, but if people want to connect with me, certainly through LinkedIn, that is definitely an option.
Well, we will tag you when we get this recording back and get it ready to post. We'll have some snippets of you saying the wonderful things that you've been saying. So you've been a great guest. I could talk to you all day. this finance discussion is not. We haven't had this discussion yet with a guest as far as this aspect of finance. We've talked to actuaries, but not the CFO. So this was really insightful for me, and I think for Paige and for all of our listeners. So we really appreciate it.
It was great to be with you all.
Okay. Well, hey, thanks everyone. We will talk next time.
Bye-bye. Have a great day.
Thanks, Anna.